this aspect particularly, that it is not only the early diagnosis, but also the early diagnosis, but also when we came to know about its specific causation, that how can we prevent it. So preventive measures also are essential, which are adequately highlighted in this text. We go from this abstract on to, and I have highlighted some of these points, which you can, one is about the incidence, that this is one of the commonest and commonest cancers still in the genital tract, despite great strides having been made. And fourth most common after breast, colorectal, and lung cancer. That was the assessment in 2012. And in low middle income countries, LMIC, that is the standard abbreviation which is used these days, the incidence is even higher. As a matter of fact, the bulk of the incidence of carcinomas of the cervix is in these countries. And again, going back to the figures of 2012, there were more than 500,000 new cases diagnosed, and more than 250,000 deaths which were attributed to that. And in low income countries, it is the second most cancer. And then in anatomical considerations, this is important, that the cancer, most of these, more than 95% cancer of the cervix, that arises from the transformation zone, which is the area of the cervix between the old and new squamocolumnar junction. The question for you is, note down, what is the old and what is the new squamocolumnar junction? Anyone amongst here who knows can raise their hands. Old and new. Anyway, go and look that up. Today, I am at the end of that, I'm also going to share with you quite a few other publications regarding carcinoma of the cervix and its various aspects. Then now we know that it is caused by high risk varieties of human papilloma virus, and 16 and 18 varieties of human papilloma virus are responsible for 71% of the cancers, whereas others 31, 33, 45, 52, and 58 are responsible for further 19%, which would make it 90%. And the other 10% are maybe they arise by some other mechanism, or they are because of some other varieties. Then it is also important to know that all women, when they become sexually active, they are exposed to human papilloma virus, and within the first couple of years of initiation of sexual contacts, about 80% of women are said to have been exposed to high-risk varieties as well. But not all of them, of course. Those infections will result in development of those changes which are precursors to carcinoma of the cervix, because most of them, those infections are cleared. And as is said here, only 1/10 of all infections become persistent, and these women could develop cervical precancerous lesions. So not all, only about 10%. And this persistence of infection, this again is that the infection persistent is one in which the same type of human papilloma virus can be identified at 6 or 12 months intervals. Only then we would say that it is persistent. But again, it's a point whether it disappears or it remains latent within the basal cells and in the form, so that it will reactivate at a later stage. Anyway, infection by one of these. And today I am also going to touch upon how are we going to, where we stand vis-a-vis HPV diagnosis, and what are various tests which are available. This again is a point that I made earlier in the talk, that prevention of invasive cancer by HPV vaccine, that these are the two aspects of carcinoma of the cervix. And second is screening for precancerous lesion. So if you vaccinate, then you can prevent carcinoma of the cervix in considerable segment of society. Uh, Here, if you look at this point 3.1 area, primary prevention of cervical cancer, more than 80% followed over time will acquire at least one high risk infection. This is the incidence. And prophylactic HPV vaccination as a preventive strategy should target women before initiation of sexual activity. That's why, so that they acquire that immunity, which will prevent them from developing the infection. And therefore, the emphasis is on 9 to 15 years of age, and here it is 10 to 14, but generally 9 to 14 years of age at that time it should be given. We know that there were three vaccines available in Pakistan. I am not sure even one is available now. One was Cervarix, which was against only 16 and 18, and the other was Gardasil, which was for 16, 18, and also 6 and 11, which are responsible for genital warts. But now in America, only non-valent, which is 9-valent, that is available, which in addition to 6, 11, and 16 and 18, also covers 31, 33, 45, and 52 and 58. Still, two probably are left out of this, but it still is 7 high risk and 2 non-risk, 6 and 11, which are responsible for genital warts. So that is, and the infection, of course, it is a recombinant vaccine, and there is no danger of getting infection by this. The dosage schedule is 0.5 ml at 0, and then after 5 to 13 months, the second dose should be given after a longer interval. Even in COVID vaccine, now we are looking at that if the interval between the first and the second dose is increased, the level of immunity generation is more forceful and more effective. And in those cases in which the second dose is given a comparatively earlier, then the third dose is given after 6 months. So in those who have immunosuppression, or in those, the doses are given 0, 1, and 6 months. And WHO has reviewed that latest data. There is no safety concern. Then secondary prevention, that is primary prevention by giving that. The highlights does not mean that you should not go through the rest of the text. Please go through that, because it is all quite important for you to understand and learn and absorb the proper message of this chapter. Then secondary prevention is by cervical cancer screening, which has been successful in preventing cancer by detection and treatment of precancerous lesions. We know that pap smear started off in late 40s and has improved, and it is effective in identifying high-grade cervical intraepithelial neoplasia, which is CIN2 and CIN3, and also adenocarcinoma in situ. Several cervical screening strategy. You know that one is the pap smear or the cervical smear, which is conventional cytology, and then liquid-based cytology, and then human papillomavirus testing, which is about which I will talk a little later, because we generally tend to think that it is something which is simple, which would be quite easily available, but that is not the case, at least in Pakistan. And therefore, the strategy, because our country also falls in that category of low and middle income countries, therefore the strategies for our countries should be different. And it is really, I made a comment about this last time also, that it's a rather sad commentary that in a country like ours, we have not been able to establish any methodology of screening the population, whereas in sub-Saharan Africa, effective programs are going on. Even in countries like Bangladesh, they have many years ago, one of our colleagues there, Professor Latifa Shamsuddin, I think it was more than 15 years ago, once I was visiting Bangladesh, and she presented a detailed account of her work in that, and she was working on visual inspection with acetic acid, which is a reasonably a good method for countries like ours, where because cervical cytology, if you look at that, it is not only collection of the specimen which anyone can do, not necessarily doctors or gynecologists, even lady health visitors or lady health workers, they can collect that. All that you have to do is expose the cervix by bivalve speculum and scrape the area of the cervix which is visible and spread it over a slide, fix it, and that's it. But the important thing is that interpretation, reading that, interpreting that, and then those findings so that they are reliable interpretations. That is the important thing. And we do not have that widespread facility of histopathologists or particularly those trained cytopathologists. And not necessarily you have to have histopathologists. It's even the technicians can perform that cytology if they are properly trained. But we haven't been able to do that. Now that is, since it is dependent upon someone else to read the slides. Visual inspection of cervix after application of 3 to 5% of acetic acid, that is something which is more practical, so that those cases in which you find that there is an issue and problem, they can then be referred for further evaluation, either colposcopy or uh, uh, taking a biopsy. And in that, I also last time gave you that what is Schiller's test and what is Liegold's iodine and what is the composition that is. So in low middle income countries, visual inspection with acetic acid is uh, 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 viable solution. Many healthcare systems are considering switching to primary HPV screening, which has higher sensitivity and negative predictive values. But I was surprised to see in an update of this, if you look at it in here, I'll show you one that currently it says, ये नहीं आ रहा, ये क्या हुआ? एक मिनट. Sorry. I actually was switching in onto two windows of. Anyway, there are only currently 2 FDA-approved primary screening tests available in the United States. I have highlighted that, and I'll give you that document. Yeah, this is it's there here. It is 2021 update guidance on cervical cancer screening for average risk women, and here you would see that only 2 FDA-approved primary screening tests. Most laboratories in the United States do not yet have the technology for primary testing, and so instead they offer one of the remaining tests, their hybrid tests, etc. Thus, many clinicians and patients, नहीं ठीक है आ गया. Thus, many clinicians and patients do not yet have access to primary HPV testing. Now, that is the situation in the United States of America in 2021. And therefore, it should not be a matter of surprise that we do not have that kind of testing facility here amongst the Pakistani population or Pakistani physician. Going back to, I'll have to again, because I thought that there would be these, it would automatically switch on or switch off to that. I have to stop and start presenting. I'll restrict myself to this presentation only. Right. So this is about secondary prevention through diagnosis of early lesions of the uh, then cervical FIGO staging. Again, this is important that in 2018, the staging has completely been transformed, and one would now go on to utilizing this staging. And this is a good chart here that describes the various stages. Stage 1, 2, 3, 4. Of course, there are all those stages, but one is A is this is when it is confined to the cervix. Essentially, you remember that. And 2 is when it is beyond the cervix. It has involved part of the vagina and part of the parametrium. And third is further extension of that. And fourth is distant metastasis or involvement of rectum or bladder. But there are these finer points. 1A and 1A has been further into 1A1, 1A2, etc., etc. So you go through that and try to have a good grasp of what it tries to say, because it is concerned with the depth of that or the extent of spread within the structure of the cervix. Here, 1A is when the maximum depth of invasion is less than 5 millimeters. It has been further subdivided into 1A1 when it is less than 3 millimeters, and 1A2, which is more than 3 millimeters but less than 5 millimeters. And 1B is when it is more than that, but this lesion is limited to cervix, but it is then visible and can be seen, or then again its dimension. So 1A is 1A1 is and 1A12, they are dependent upon the microscopic depth of invasion. 1B is related to its appearance, where it can be seen that the largest dimension 1B1 is when it is less than 2 centimeters, 1B2 is when it is more than 2 centimeters, and 4 less than 4 centimeters, and so on. So these are further minor classifications which will be relevant when one takes up the treatment. So stage 1A1 and 1A2 is made on microscopic examination of a biopsy specimen, which may have been taken through a punch biopsy, but not punch biopsy, because punch biopsy is generally taken for, is suitable only for fungating obvious lesions. But when you are making a diagnosis of what used to be said as carcinoma in situ, and that was not really considered invasive cancer, that was a different thing. Now, in invasive cancer, the, when you go on for microscopic examination, it is essential to know that the depth is limited to what has been described in this staging. And that can only be done if there is, you can find that there is a normal structure area beyond the affected part of the cervical tissue. And therefore, it is important to know that normal area around that. And that can only be done if there is that substantial part of the cervix, which, for example, is taken by cone biopsy, or here by LEAP, or the other is LETS. So loop electrosurgical excision procedure, or then there is loop electrosurgical excision of the transformation zone. So these are the two methods by which you can take in addition to cone biopsy, which includes the entire lesion. And there you then so the horizontal dimension is no longer considered in 2018, etc. So this is important that you follow this classification of carcinoma of the cervix. Now, Invasive disease is case of visible lesion. In those where there is visible lesion, in those you can take a punch biopsy, but it is, if not satisfactory, a small loop biopsy or cone may be required. Clinical assessment is the first step in allocational staging. That's important. But previously, the staging was done only on clinical EUA, for example, and the palpatory method, and what it was like that. But now, since we are concerned with the depth of involvement, which is again in millimeters, etc., so therefore histology comes into play as well. And therefore, the revised staging permits the use of any of, in addition to that, imaging modalities. And that is that you can take on is ultrasound, CT, MRI, and PET scan. So clinical staging is one part. Second is imaging, and third is pathological staging. So this is how now carcinoma of the cervix is to be. FIGO no longer mandates any biochemical investigation or investigative procedures. However, in patients with frank invasive cancer, a chest X-ray and assessment of hydronephrosis with renal ultrasound, intravenous pyelography, CTA, or MI should be done. The bladder and rectum are evaluated by cystoscopy and sigmoidoscopy only if the patient is clinical symptomatic. Previously, that was, so you can highlight that, cystoscopy and sigmoidoscopy. Now, sometimes it may happen that a hysterectomy is carried out, not knowing that there may be carcinoma of the cervix, and there one finds that there is carcinoma, that the management problems which are attended with that kind of situation that we'll see later. And after surgical treatment of the cancer, in case of surgical specimen where it is available and where image guiding fine needle aspiration cytology has been done, the pathological report is an important source for accurate assessment of the extent of the disease, whether it has gone up to certain nodes or not, whether they are involved or not. So that's important. The stage is to be allocated after all imaging and pathology reports are available. This is a key factor, that in addition to the clinical assessment, imaging, and pathology report, only then you finalize the staging. In some cases, hysterectomy is performed in the presence of unsuspected invasive cervical lesion that is diagnosed later on histopathology. Such cases cannot be clinically staged or included in therapeutic statistics, but that is only for research purposes or for studies. But if that is done, then the staging of the disease would be difficult. Histopathologically, cases are classified carcinoma of the cervix if the primary growth is in the cervix. And these are the various varieties. Mavish presented that, probably. You presented that and you showed all these. Then grading, well differentiated, moderate differentiated, and poorly differentiated. Surgical management is suitable for early stages. Microinvasive cervical carcinoma, stage 1A, 1, etc. You go through these, but the important table that I want to show you, that is this one. This describes various types of hysterectomies and the extent of the structures which are removed at that time. Simple extrafacial hysterectomy is the one that we generally do. That is known as extrafacial hysterectomy. Because when you open up the peritoneum of the pelvis, like I would signify that, when you start picking up the peritoneum, say at the pelvic brim, and unfold it or strip it away from the underlying structures, or you open up the broad ligament and you look at the parametrium, then you are not extrafacial, then you go intrafacial. So if you start removing say, the lymphatic channels and lymph nodes along the internal or external or both iliac arteries, then that is going intrafacial. So long as we are performing the way we perform generally hysterectomies, that is extrafacial, because we are not opening up the peritoneum as such. We are not unfolding the peritoneum and exposing the structures which are underlying the peritoneum. So these are various structures that this is type 1 or type A, B, C, or and indications for that. And here it is important, I would want to highlight that surgical treatment or radical hysterectomy is suitable only for up to stage 2A, and which is not extending to the parametrium, but which extends to the upper part of the vagina only. In that, up to that. And whenever we talk about surgical treatment of carcinoma of the cervix, it must be given or mentioned with the proviso where facilities or expertise for that is available. So it must be carried out by a trained gynecological oncologic surgeon. It is not really within the domain of a general gynecologist to do that. And for example, here, if you look at what we do in routine extrafacial hysterectomy, is that we catch hold of cardinal ligament and uterosacral ligament as one. Remember? In these. Now, whereas, and these are divided close to the cervix. We remain as close to the cervix and the uterus as is possible. So, which is divided at uterine and cervical border. In type 2, which is modified radical hysterectomy, the cardinal ligaments are divided where ureter transits the broad ligament. So therefore, you have to dissect and see where the ureter is, which normally you in extrafacial hysterectomy you don't do. And in the third one, which is proper radical hysterectomy, then it is divided at the pelvic side. So therefore, before you divide that, you have to dissect and separate the ureter and extract the ureter from which is called the ureteric tunnel within the cardinal ligament. So you have to dissect that. You have to go on to that kind of surgical approach. So these are the various steps which are illustrated in this or explained in this chart. Then for stages 1B3 and 2A2, the tumors are large and the likelihood of high risk factors, positive lymph nodes, positive parametrium, or positive surgical margins that increases the risk of recurrence and require adjuvant radiation after surgery are high. And then there are other risk factors, pelvic recurrence, even when nodes are not involved, large tumor diameter more than 4 centimeter, and lymphovascular spread, and invasion of outer 1/3 of the cervical stroma. In such cases, adjuvant whole pelvic irradiation reduces the local failure rate and improves progression-free survival compared with patients treated with surgery alone. However, the dual modality treatment increases the risk of major morbidity for the patient. This is to be highlighted, and therefore the conclusion would be the treatment modality must therefore be determined based on the availability of resources and tumor and patient related factors. So these are the important and then there is concurrent chemotherapy, chemoradiation. So concurrent platinum-based chemoradiation is the preferred treatment option for stage So this is the important aspect of this. In areas where radiotherapy facilities are scarce, neoadjuvant chemotherapy has been used with goal of But you would, for your examination purposes and for your clinical management cases, you remain up to that and forget about that new adjuvant, etc. And then suddenly it comes to stage 4A. उसके लिए तो फिर है ही ये सारी radiotherapy and chemotherapy. Radiation management, majority of patients present with locally advanced disease where surgery plays a limited role and radiotherapy has an important role. Now, if the surgical expertise, relevant surgical expertise is not available even for early stage, I would recommend that the patient should be sent for radiotherapy because that would give the patient a better chance of survival than incomplete surgery. Apart from its curative role, radiotherapy can also be used as adjuvant therapy for operated patients to prevent loco-regional recurrence. Because later on, it is mentioned at places that where a hysterectomy is performed without diagnosing carcinoma of the cervix. In those cases, when radiotherapy is given, it is less effective compared to those in which proper surgery has been done or in which only radiotherapy is given. So, incomplete surgery plus radiotherapy is inferior to radiotherapy alone. In these radiation therapy for early stages, surgery is preferred for early stage disease in cases with contraindications for surgery or anesthesia. And radiotherapy provides equally good results in terms of local control and survival. So this again is an important point which I was trying to make right now, that if only proper surgical training and expertise is available, only then it should be carried out. Otherwise, radiotherapy would be a better option. Now, this is dose of 60 to 65 GY equivalent is usually prescribed to point A. What is point A? तो हम लोगों ने पढ़ा हुआ है चैप्टर ये. I know. This is important. Actually, it is important. Anyone who would say what is point A? Point A is 2 centimeters above and lateral to the transformation zone. 2 centimeters. And that is the point where maximum radiation is to be given. Because there are 2 types of radiations which are given. What are those 2 types? Hello? 2 types of radiation. One is intracavitary radiation and the other is external beam radiation. All that is focused. And here, the dose, this GY, how do you pronounce that? Gray, right. So a dose of 60 to 65 gray is given. And do you know what is the lethal dose of radiation for a human being? If it is given to whole body, what is the dose of, in grays, what is the dose of radiation? How much would that be? Can one guess? All right, I'll tell you. It is 5. Only 5 grays. 5 grays radiation to whole body. If it is given to whole body, the person would die in 2 weeks' time. And here you are giving 60 to 65 grays equivalents to point A, because it is now given to a focused area only. That is to put into perspective the intensity of radiation which is provided to that point. And that is the significance of that point A. Previously, I mentioned in my last discussion that there used to be 3 methods of providing irradiation intracavitary. One was Manchester, one was Paris, and Stockholm. Those there were these three centers which had established their own. One was intracavitary oblong or longer cylindrical container, which had, and then there used to be two blocks which were placed on the lateral fornices in the vagina. And they were placed in such a fashion so that the maximum irradiation would go to that point A. So those were, that is intracavitary. And when it is given through external beam irradiation, then of course it has to be identified by imaging that where is the cervix and all that, and only then it is given like that. So there is this post-operative radiation, etc., and adjuvant radiotherapy. Following radical hysterectomy, post-operative radiotherapy with or without chemotherapy is indicated for patients with the adverse pathological factors such as positive pelvic nodes, pelvic parametrial infiltration, positive margins, or deep stromal invasion, etc. So that is adjuvant radiotherapy. ये चैप्टर चूंकि मैंने आप लोगों को देना है तो इसलिए मैं साथ में हाईलाइट कर रहा हूँ आपके लिए और आइंदा अपने लिए भी. Tumor size of more than 4 centimeters is well-known risk factors. Post-operative radiotherapy consists of whole pelvic external beam radiation therapy to cover the tumor bed and draining lymph node areas. For FIGO stage 1B3, although feasible, surgery as initial treatment is not encouraged for patients with stage 1B3 and 2A2 disease, since 80% of them require post-operative radiation therapy or concurrent chemoradiotherapy. ये ज़्यादा जो डिटेल है इस पे बेशक ना जाएं. रेडिएशन थेरेपी फॉर FIGO stage 2B1 ये आ गया, ये निकल गया. Then patients presenting with distant metastatic disease, presentation with distant metastatic disease is rare, reported in about 2% of cases, and the survival time is approximately 7 months. So poor prognosis. And radiation therapy for inadvertent incomplete surgery, inadvertent simple hysterectomy. Extent of the disease should be assessed by PET scan, etc., or outcome for such patients even after post-operative radiotherapy remains very poor, with 5-year recurrence-free survival of 49%. Therefore, concomitant chemoradiation therapy is generally added. Post-treatment follow-up, ये आप जरा देख लीजिएगा, ये मैं इसी तरह से दे रहा हूँ आपको. और ये लोकल रिकरेंस वाली बात है, रिकरेंस को कैसे मैनेज करना है. And then the special circumstance, if there is cervical cancer during pregnancy, then before 16, 12, 20 weeks of pregnancy, patients are treated without delay. And when beyond that, when delivered at a tertiary center with appropriate neonatal care, delivery by classical cesarean section, radical hysterectomy at the same time is undertaken not later than 34 weeks of pregnancy. तो उस वक्त उसको वो करते. So this was this. What I also want to now bring to your notice are about a couple of other documents. आ गया. This is only a small document, but it shows current state of HPV vaccination and the impact what it has made on the routine vaccination is recommended at age 11, 12, but it may be given as young as 9, and 2 doses 1 year apart. Vaccination at age 27 to 45. What are the implications of that, and what are the recommendations by various bodies? And decline in HPV infections has been significant, which was seen between 2003 and 2014. And also the effect. No, HPV vaccine is not a complete protection against. That does not mean that the patient cannot be, because important question is that those girls who have had HPV vaccination, do they need to have screening? The answer is yes. How much protection is that? This is the recent Swedish study which has come up that among girls who were vaccinated at younger than 17 years of age, there were only 2 cases of cancer in a large uh, group, in contrast to 17 cases among those who were vaccinated after the age of 17. Cervical cancer screening for average risk. I refer to the tests which are available, and thus many clinicians and patients do not have access to primary HPV vaccination. And third is this is the American Society for Colposcopy and Cervical Pathology. Management guidelines focus on individualized risk management. How are you going to uh, uh, stratify the patients who are screened? So these are some of the highlighted points, and this is a flow chart for cervical cancer screening and its management, which is included in this chapter. And then there are a few others. Probably I will be able to show that. Let me see if I can. Yeah, this is another paper which looks at, this was published in Lancet, estimates of incidence and mortality of cervical cancer in 2018, a worldwide analysis. It gives charts and graphs and these uh, infographics as well. This is the incidence and mortality in various countries, and you can find Pakistan also amongst them. And then this is, if one is interested, this is a very long article, but this is 2019 again, American Society for Colposcopy and Cervical Pathology, risk-based management guidelines for abnormal cervical cancer screening tests and cancer precursors. If you are interested in that, you can look at that. And this is a recent article. This is only a 2-page article, I believe. This was managing minimally abnormal cervical cancer test results. I would suggest that you read this also. And this is cervical cancer prevention and low. It is only for those who are interested in starting a program like that. But this is what is the effect of HPV vaccine on cervical cancer? That is, vaccination has no therapeutic effect against pre-existing HPV infection. And HPV vaccination was associated with substantially reduced risk for invasive cervical cancer at the population level. And vaccination before HPV infection exposure to achieve the greatest benefit. An implication for healthcare due to the fact that risk reduction was even greater among women vaccinated at a younger age. It is important for the healthcare to provide age-appropriate education related to that. Common questions about 9-valent HPV vaccine. I thought, and then this is only about 5 pages. But cervical cancer treatment, this is a summary of that. Treatment recommendation for early stage disease, for stage 1A2, 1B and 2A, advanced disease, treatment recommendation for metastatic. So in 2 pages, it is a summary of that treatment. And then it also summarizes here the chemotherapy. So I'll put all these, except for that low middle income countries on that. Any comments? آواز جا بھی رہی تھی کہ نہیں کسی نے کہا؟ رائٹ چلیں یہ پھر ابھی بھی کر دیں آپ کے اس میں میں دے دیتا ہوں یہ سارے آج ہی کر دوں گا میں پھر ٹھیک ہے. If there are any questions, I think that we should form a platform on or a group on WhatsApp on which the queries can be sent, and then one can address those queries in the next session. We can say keep about 10 minutes for addressing the queries which were raised in the previous presentation, and then about 30 minutes for the presentation and 10 minutes for summarizing and looking at that. Share these articles. Sure, بالکل کرتے ہیں. Good. وہ بنا لیں آپ. کون بنائے گا؟ نہیں واٹس ایپ کو عمران سے بھی پک لینا بنا لے گی. ان میں آپ یہ اتنے سارے ڈاکٹرز ہیں سب کو آپ اس میں وہ ہے نا ان کا گروپ جن میں آپ شیئر کرتے ہیں تو یہ آپ کر دینا اس کے اوپر. یہ لے جی میں ابھی یہ آرٹیکل جو ہیں I'll try to share these. ٹیلیگرام پہ کن کو شیئر کر سکتے ہیں جو آپ کے آرٹیکلز ہیں بنے ہوئے ہیں سر. یہ میں تم لوگوں کو دکھاؤں ویسے میرے پاس جتنے جو چیزیں ہیں یہ ہاں وہ ایک منٹ ٹھہرو. یہ دیکھو پاکستان کا جو ہے نا وہ امپورٹنٹ تھا ایک وہ والی جو چیز میں نے اس کا یہ والا تھا. ہاں یہ گلوبوکون ہے. گلوبوکون 2020 کا پاکستان کا ہے. نمبر آف نیو کیسز ان چلو ادھر دیکھ لینا. سو یہ ہے مختلف کینسرز کا اس کے اندر دیا ہوا ہے. یہ سروکس کا یہاں پہ آ رہا ہے. یہ یہاں پہ یہ اسی طرح سے آپ اینڈ دیز آر امپورٹنٹ ریلیونٹ فگرز اباؤٹ ویریئس کینسرز. بریسٹ کا لیپ اورل لنگ اس کا یہ اووری کولوریکٹم اور so this also would be relevant so that you have some یہ ایک پیپر بھی ویسے چھپا ہوا تھا یہاں اس کا پریویو بھی پاکستان میں یہ بھی تھا سروائکل کینسر ان پاکستان ریویو اس کا ہے. اور اس میں جو امپورٹنٹ ہے اس کی گائنیکولوجیکل انکولوجی کا یہ ہے فیگو کا 2018 کا. فیگو 2018 میں یو وڈ سی یہاں پہ یہ مختلف چیپٹرز ہیں. کینسر آف دا ولوا کا الگ چیپٹر ہے اور وجائنا یہ سارے اس طرح سے یہ شروع ہو جاتے ہیں. پیلیٹیو دیر آر اباؤٹ 16. تو میں آج یہ چیپٹر ڈھونڈتا رہا جس کو میں نے پہلے ہائی لائٹ کر کے رکھا ہوا تھا. وہ مجھے نظر نہیں آیا. اس کو میں نے یہاں پہ یہ والا تھا یہ پہلے تھا جس کو میں نے ہائی لائٹ کیا تھا. آج پھر مجھے نئے سرے سے ہائی لائٹ کرنا پڑا اس کو سارا. چلیں جی. ہاں یہ اس میں بھی ہائی لائٹ کیا ہوا تھا میں نے اصل میں. یہ اس میں ڈفرینٹ ہائی لائٹڈ ہوگا ذرا وہ اور طرح سے تھا. اس میں اتنا زیادہ نہیں کیا ہوا تھا. سلائٹلی ڈفرینٹ ہے جی. چلیں جی ٹھیک ہے. اوکے تھینک یو ویری مچ. ہاں یہاں سے اسٹاپ پریزنٹ